Old mocker Lichtenberg was truly right in his prophecy on tubes 300 years ago in Figure 01. We start with a series of esophageal findings and with a carcinoma in Figure 2 in transverse sections. 03 is their remote bolus obstruction. Clinics and history are leading here, of course, too. In 04, it is spondylofites causing dysphagia. And in 05, it is a cardiac carcinoma which is responsible for the clinical complaints, whereas it is an esophageal prosthesis in 06 filling the lumen. In Figure 07, it is a big alteration confirmed by endoscopia, first seen in echoscopia. And in Figure 08, wall thickening is caused by an antral carcinoma, whereas a linitis plastica is demonstrated in Figure 09 in bubble technology. Another alteration, now in the duodenal bulb, is seen in Figure 10, whereas Figure 11 shows a case of portal hypertension. And in Figure 12, the rare finding of sludge collections inside the DHC. And in Figure 13, intrahepatically as well. A dislocated biliary stent is in Figure 14 demonstrated. In Figure 15, it is a unilateral congestion demonstrated due to a highly located Klatskin tumor. And in Figure 16a, it is a biliary necrotizing pancreatitis shown in bubble technology in Figure 16b. In Figure 17, it is a pseudocyst invasive to the spleen. And in Figure 18, a pancreatic tail carcinoma is to be seen aside a bi-spleen. Fundus varices in another case are seen in Figure 19, whereas in Figure 20 is shown liver metastasis of an urothelial carcinoma. A huge birenal malignoma is seen in Figure 21, and Figure 22 demonstrates a small pleural effusion and again the gliding phenomenon. In Figure 23, it is a mesothelioma to be seen. And in Figure 24, it is a huge pulmonary mass demonstrated with the diagnostic fine needle puncture. Another fine needle puncture is shown in Figure 25 in an adrenal tumor and a probable bronchial carcinoma. In Figure 26, fine needle puncture again. In Figure 27, the too harmless FLs must not lead to overlooking the third one, which is a malignant. In Figure 28A and B, different approaches to the same tumor are demonstrated. and some pleural masses are shown in figure 29, which are probably metastatic. In figure 30, it is hepatic artery in cirrhosis, not the DHC. Truly dilated is DHC in figure 31, however. And in figure 32 as well, medium-grade dilatation. Figure 33 and 34 are two different cases of PSC. Please note lymphadenopathia in figure 33. Another papilla carcinoma with a distension is to be seen in figure 35. The stent is not effective. Figure 37 shows an asymptomatic choledocholithiasis, and in figure 38 it is another stent which is by sludge obturated. And in figure 39 there is a liver cirrhosis, distended intrahepatic bile duct in 39A without, and in 39B with the CF. And in figure 40 there you find active splenic bleeding in a boy with a bicycle accident. Case figure 41 demonstrates a splenic echinococosis. A pseudocyst invasive to the spleen is documented in figure 42, whilst in figure 43 it is pictured the case of a sarcoma of os pubis without and with bubble technology. Case figure 44 is dedicated to Wirsungio after ample sphincterotomy. Figure 45 shows a case of chronic pancreatitis, and in 45A it is echographia, in 45B ERP. In case 46 it was, however, ductal neoplasia responsible of morphological changes, whereas in case 47 it turned out to be a linear thrombosis in chronic pancreatitis. In figure 48 it was acute biliary pancreatitis responsible of this necrosis. Figure 49 is the very early onset, some hours only, of a presumably vascular pancreatitis. Figure 50 is due to a peritoneal carcinosis. This case, however, was caused by peritoneal tuberculosis, whilst the case in 52A and B pictures a typical result in interventional echographia drainage. Figure 53 is a case combined with erbilia and an example for gallstone ileus. And in case figure 54, it is a Bouveret syndrome documented after first ESWL session, whereas the case is a liver cyst with a coagula only. Figure 56 shows a liver traumatic rupture, no bleeding, whereas in figure 57 one finds a bleeding urinary bladder tumor. And in case 58, a severe chronic urinary cystitis with a wall thickening. In figure 59, it is a psoas abscess causing clinical symptoms. And in figure 60A and 60B, an unspecific diarrhea in echoscopia and endoscopia respectively. Figure 61 shows a diverticulitis. Please no palpation by the end. In figure 62A is shown the echoscopic and in B the endotherapeutic aspects of a phlegmona. Next case in figure 63 shows a femoral herniation, and in figure 64 is demonstrated a neuroendocrine tumor at a valvular site. Case in figure 65 shows a perforated tooth stick, and in figure 66 a patient is shown with the swollen lymph nodes. And in figure 67, it is another urinary bladder tumor. In figure 68 is shown intrahepatic PSC. Whilst changes in figure 69 belong to the portal venous system, the case in figure 70 is another peritoneal and pleural carcinosis again. Figure 71 demonstrates enhanced biliary pressure with a distended cystic duct. And finally, figures 72A and B represent an asymptomatic amyloidosis.